Good morning. This is Dr. Nick Tullo from New Jersey with my clinical live stream. This is number 20. Can you believe it? So I'm really happy that things have been going well. I finally got a lot of the bugs worked out of it, and I'm still working on my new production studio. So for today, unfortunately, we're still stuck with this sort of a messy, office. But hopefully, maybe next week, it'll be the new environment. Anyway, we have a really cool case. If you don't know already, I'm a cardiac electrophysiologist, so I deal with arrhythmias all the time, and pacemakers, and patients with bradycardia, tachycardia, all that kind of stuff. And I came upon a case, in fact, it was just this week, so I thought it was a really cool case to present, because you guys, you want to kind of like see how the experts think. Those of you who are involved with cardiology or arrhythmias or even just taking care of patients, if you have any comments, by the way, please add to the chat screen. I'll glance over, and in fact I'll just say hi just to make sure that everybody is watching. I do believe I'm streaming live, so anyway, welcome to those of you who are here. So we're going to talk a little bit about TAVR, which is transcatheter aortic valve replacement. And I just want to, someone sent me a comment just to make sure that we are live. It looks like we're live. Hey, Richard. Hey, thanks. And SpaceFed 101. Good morning. From Malaysia. Wow, cool. So now at least I know I'm out there, right? You never can tell. It's one of those things. I don't have a whole crew of people behind me. It's just me, little old me. I'm sort of like the AV whiz and electrophysiologist at the same time. Jazzwinder, thank you for joining us. So we're going to talk a little bit about transcatheter aortic valve replacement, TAVR. We've been doing it in my hospital for a couple of years now. It's really very, I wouldn't even say up and coming. It's now sort of mainstream that patients who are especially high risk, older patients who have aortic stenosis can have this procedure done instead of an open heart surgical aortic valve replacement. So let me just show you what that looks like. Here's a picture of my screen. So now I have to give credit to the Mayo Clinic. This was from their website. But if I can just, jazz this up a little bit, make it, that may be too big. But the idea is that when you have aortic stenosis, let's just see if I can drag this over a little bit. If you have aortic stenosis, then the aortic valve, which is, here's the aortic root right here. I'm going to make this a lighter color so you can see it. So here's the aortic root, and your aortic valve is very, very tight. The blood has a hard time getting out of the left ventricle, and the valve kind of looks like this. So what they do, normally they would open the chest and they would open the aorta and remove the valve, scrape it out, and then put an artificial valve. But what TAVR does is they go up through the femoral vein, the femoral artery. I'm just sort of like waking up. It's early on a Saturday morning. Actually, I've been up for 3 hours already getting ready for this. So they go through the femoral artery and they snake a catheter up and they put a guide wire across this tight aortic valve, and then over that guide wire they advance a balloon, and on top of the balloon is this valve prosthesis, this valve replacement device that then when they inflate the balloon, it deploys this device in the aortic root, and it allows patients to have a new aortic valve without open heart surgery. It's really kind of a cool way of solving this problem with much less risk than an open heart surgical procedure. This is it's commonly done, but now here's the problem: is that on the septum here, the left ventricular septum, What structures do we find in the left ventricular septum? Well, the conduction system particularly. And sometimes deploying this valve in the aortic root, especially when you have calcified aortic disease, the calcification can sometimes penetrate into the septum and the aortic root, and it can affect the conduction system. And then also deploying this valve sometimes applies pressure to the conduction system. And so it's not uncommon for people to develop bradycardia, in particular AV block, after this procedure. So that's why it's important to monitor people for at least a couple of days afterwards to make sure they're not having problems with bradycardia. So let me present this case to you. So the case that we're going to talk about is actually is a patient who had a TAVR a year and a half ago. Okay, this was a patient who is 93 years old at the time and had severe aortic stenosis, normal left ventricular function, and was recommended to have a TAVR because he was having symptoms from his aortic stenosis. So let me share with you the ECG, the baseline ECG, before he got his TAVR. So this is his cardiogram before the TAVR. So if anybody wants to, take a minute to look at this thing, it does show some problems. Number one, the rhythm is irregular, and it would appear that there aren't any visible P waves anywhere. You can see a very fine fibrillatory activity in some of the leads, and it's on the slow side. It's running around in the 60s mostly. So this was a baseline ECG that shows atrial fibrillation with a moderate ventricular response, kind of a little on the slow side. Now, would anybody call this a bundle branch block? Because the QRS complex does look a little bit wide, doesn't it? It's probably about 120 milliseconds or so. And when you look at V1, V2, V3, it almost kind of has a left bundle branch block looking appearance, but 1 and AVL do not look like the typical slurred upstroke notch kind of QRS. So I would not call this a left bundle. I would call this a nonspecific IVCD. Good morning, Matilda. Glad you could make it. So I would call this a nonspecific IVCD. And so what happened was, immediately after the TAVR, the patient wound up being profoundly bradycardic. In fact, they had put a temporary pacemaker at the time of the procedure, and he used it for about 24 hours. But after 24 hours, his conduction returned, and his ECG looked about the same as it did before. So, there's a lot of controversy about what should be the threshold of implanting a pacemaker in someone after TAVR, whether they need to be paced or supported, and especially if you see a new left bundle branch block, or if you see profound bradycardia that doesn't get better within 24 hours, those patients may be at high risk of having serious problems of persistent bradycardia. And a lot of times people will implant pacemakers if they see a new left bundle. But sometimes if the valve prosthesis infringes on the left bundle, but the right bundle is still intact and the right bundle is still conducting properly, then they may not need a pacemaker, because people can live with a left bundle branch block, and it doesn't necessarily mean that they're going to develop serious problems. So some electrophysiologists have they've gotten in the habit of doing a His bundle study in patients who have a new left bundle after a TAVR. And they'll measure the HV interval, and if it's very long, they'll go ahead and they'll put a pacemaker. But if it's relatively normal, 55 or 65, normal is 35 to 55. So if it's only a little bit prolonged, they may forego the pacemaker and may leave it. And this patient did not have a new left bundle. After 24 hours, he stopped using the pacemaker, and he went back into that sort of, moderate, slow atrial fibrillation. After the procedure, he sort of came back to this look to his ECG, and so we decided not to do anything. We sent him home, and he did really well for about a year and a half. So then what happened was he, at home, suddenly had serious symptoms, lightheadedness, weakness, profound weakness, was diaphoretic, looked awful. So they called 911 and they brought him to the emergency room. And so this was the ECG. Now this is a year and a half after TAVR. And here's what you see. This was his presenting electrocardiogram. And he felt just awful. His heart rate was like 20 in the ambulance on the way to the hospital. And what we see here is, he still has what looks like atrial fibrillation. I still don't see any P waves to speak of, but the conduction is extremely slow. Now he does have evidence of more of a classic left bundle branch block. But then in V1 here, you have some conductive beats that look like they have a right bundle branch block. Now, how many of these, this could be a PVC because it occurred so quickly. I think the underlying rhythm was, about 20 or 30 beats per minute. Good morning, Larry. And hello, Christoph. Good morning. The new valve, how is the new valve secure in the aorta? It's, it's like just like a stent. When you blow up the balloon, the device is designed to expand and remain the size that you expand it to. It's like the metal struts kind of like stretch apart, and they're held in place by this sort of like stentish looking scaffold. Okay, so once you expand it and it kind of grabs hold of the aorta, it will stay there, and it actually does pretty well. So at any rate, here now the guy is profoundly bradycardic, and but this was a year and a half later. So it's interesting how you might want to blame the TAVR, but now he's 95 years old, and 95-year-old people get conduction system disease. So I can't be entirely convinced that this was from the TAVR, but anyway, what did we do? What do you do with a guy like this? He's awake, and his blood pressure is okay, but his heart rate is obviously hanging by a thread. So one of my partners actually was on call, came in early, Manchester by the Sea. Thanks, Janet, for joining us. He put a temporary pacemaker in. And we basically brought him to the cath lab, and he did it under fluoroscopy. So he kind of knew that it was in a decent position. And he sort of added a little bit of wire to sort of like give a little bit of, slack in the lead. And they sent him off to the CCU, and I was supposed to see the patient and figure out what to do. Obviously, it looks like he needs a permanent pacemaker, doesn't he? But at this point, his pupils were fixed and dilated. He actually had coded for a short time. I failed to mention that. But he was so bradycardic, and he was asystolic for a while. Then he went into VF, and then he was shocked. So the guy was in pretty bad shape. And that's why we didn't just put a permanent pacemaker in. We put a temporary wire in. So then I came in the morning, and before that, but they were actually able to get his heart to speed up a little bit. And actually, they gave him a couple of milligrams of atropine, and it didn't work, but they gave him isoproterenol. And isoproterenol, as you know, is a pure beta agonist that gooses the conduction system, and we were actually able to get him to conduct a little bit faster, although he still has this very wide QRS. So anyway, he got this temporary pacemaker, and the next morning I come in, and I noticed this on his rhythm. And apparently what they did was they rolled him over to sort of like clean him up. And this is what I saw. Now this is what happened about 3 in the morning after he got the pacemaker. As you can see, he has these pacing spikes, and he has a QRS that looks like it's upright here, and he's pacing and everything is fine because there's a QRS following every pacing spike. But then here we have a pacing spike, but no QRS after it. And then here we have another pacing spike with no QRS after it. And then a couple more. So what do you think happened here? Did the pacemaker battery need to be changed? The temporary external pacemaker battery? What I noticed is that the QRS morphology following the pacemaker spike was up here, and now all of a sudden it's down. Okay? What do you think happened? Wyatt's right, it's failing to capture, and I think because they moved him, the wire must have come loose and moved to a different spot in the right ventricle, which would explain why the QRS complex changed from being upright in this lead to being downgoing. Now this is a serious problem. Now this happened at 3 in the morning, and the residents recognized the issue. But what you need to do is just recognize the fact that anytime you lose capture is potentially a serious problem, especially with this patient because his conduction system is so tenuous. So here's what happened following that. He starts having quite a few pacing spikes that are failing to capture. And remember, he has a very poor conduction system to begin with. So this becomes a medical emergency very, very quickly. The next EKG tells the whole story. All right, so this was 3:15 in the morning, and basically the pacemaker stops capturing altogether, and he has no rhythm. He has atrial fibrillation with 0 ventricular response. So the patient, they coded him again. They were able to manage to get some isoproterenol up. They were able to get him back, and but one of the things that they did was they applied an external transcutaneous pacemaker. And what I want to show you is this strip, which shows these large artifacts from the transcutaneous pacemaker. But do you see anything wrong with this picture? This, although you have these transcutaneous pacing spikes, the only QRS that I see is right here. So, and in fact, if you look at the pulse oximeter, you really don't see any waveform here to speak of, except maybe this one. So the external pacemaker is not capturing here. It's not doing anything. This was at 6 in the morning as I walked in the door. And so I did manage to turn the MA up on the transcutaneous pacemaker. And we were able to get the transcutaneous pacemaker to capture intermittently. And we also gave him isoproterenol. So with this strip, we now see a waveform in the pulse oximeter. And that means that the heart's beating. But where are the QRS complexes? Because here are the spikes, here and here and here. But there's a QRS that's coming before the spike. So the patient actually has his own intrinsic rhythm. Down here, as you see, he has his own intrinsic rhythm in between the spikes. Now this spike looks like it captures because it has a QRS following the spike. And you can actually see these waveforms speed up a little bit. But this does not capture because now you see the QRS is much later. So even at high output, this transcutaneous pacemaker was not doing well. You need to be able to recognize when it's working or not. You really need to be able to tell if your therapy is working. And unfortunately, this was not. So it became a real serious problem. Turning off the pacemaker, you can see that the patient now has an escape rhythm, but it's a very slow idioventricular, wide, bizarre looking at a rate of about 20 beats per minute. So we had a bad problem on our hands. So what happened was I wound up going to the cath lab. I was like, please help me, help me, help me. So, but the nurses were very nice. They were able to free up a room. They got some staff. We wheeled him over. And he was now on isoproterenol. So we had a rhythm. It was very slow. And every now and then, intermittently, this transvenous pacemaker would capture. But nevertheless, we put a brand new wire up from the other side, and I was able to get it in a better spot. And so we were able to get it to capture. And saved his life because he was not going to do well. So at any rate, this was after the new transvenous pacemaker went in. And you can see now the QRS looks a little bit different because it's in a different spot in the heart, but it is capturing every beat. And this beat just looks like a PVC, but it's sensed appropriately. And so we were able to stabilize the guy. So what would you do at this point? Well, we waited a day, and then we decided to reassess his brain function before we went ahead and put a permanent pacemaker in. But the family was very anxious to do everything possible, even though he's 95. And the next day, he was somewhat responsive to stimulus. He was still sedated on a ventilator. But we decided to go ahead and put the permanent pacemaker in. So I just want to share with you what that looks like. So anyway, I've got a couple of interesting videos here. Just to play some of the videos. So when I put pacemakers in, when I put permanent pacemakers in, oops, I have to show you this. Okay, I didn't show you the, we weren't on the screen. See, I have to think about 11 different things at one time when I'm doing these live streams. But this was, in fact, the pacemaker that I inserted, and the PVC, and everything is fine. The patient's stable. So now we're going to go over to the pacemaker implant. So I always do a venogram. Now I don't know if how many of you are inserting pacemakers. So when I learned how to do pacemakers, I used to do just a subclavian stick. It would be blind, and there was a couple of 3% of patients would get a pneumothorax. You could get bleeding. It was kind of, that was the riskiest part of the procedure. I never do that anymore. For a while, I did cephalic vein cut downs, which avoid the possibility of a pneumothorax, but then you're doing much more surgery. Sometimes you don't find a suitable vein. So what I do now is I do a venogram, and here's the venogram. I'm going to maybe blow this up, make it a little bit larger. Okay. So here's the venogram that's sort of like looping. And maybe I can draw a little bit of the anatomy on here. So I've, let me see if I can stop this for a second. So, okay. We've made the incision. The incision is, right about here someplace. I have self-retaining retractors, Wheatlanders in here. And what you see here is let me use a brighter color. You can see the clavicle is here, right? And then this is the first rib, and it crosses over the clavicle. So if you were doing a blind stick, you would probably, wind up sticking the subclavian vein here someplace. This is actually the second rib. Now these are the anterior ribs, right? The posterior ribs kind of are the ones that go in this direction. So that's the posterior rib. But the anterior rib, the second anterior rib is right here. And for a guy his age, he actually has some pretty good calcification. I mean, his bones are still ossified. They're still pretty easy to see. So we give 10 cc's of contrast into the intravenous, and it always helps to have the IV on the left side. it has to be on the left side, obviously, because you give this injection of contrast. And what you can see is a little tiny cephalic vein that really would be unusable to put a pacemaker lead in. But here's the axillary vein that's going across. And as you know, the axillary vein runs across the chest, and as soon as it crosses under the clavicle, it becomes the subclavian vein. And you can see the subclavian vein, leads to the right atrium this way. So all along here is fruit for sticking the axillary vein. What I always do is I find that second anterior rib, which is right here. Use a brighter color. So that second anterior rib runs right over here. And that's my target. I want to try to hit the vein where it overlies the rib. Why? Because if I go too deep, instead of hitting the lung, I'll just hit the rib. And then you're not doing any harm. So it really worked out well. I was able to puncture the vein, slip the pacemaker lead in, and now I'll show you the pacemaker lead is in the next video. I'll show you that. Okay, now with this video, you're seeing the TAVR here, which I'll point out to you. Make sure I'm drawing on the right layer. So I have to stop the video to draw on it. So this sort of like webbing here, this net that looks like chicken coop wire, that's actually the valve that's deployed in the aortic root. So that's the TAVR. This is a patient who had bypass surgery in the past. We won't talk about that, but it doesn't really matter. The temporary pacemaker that I inserted comes up this way and is kind of like stuck sort of on the low part of the septum. So now the permanent pacemaker wire that I just inserted into the vein comes down the superior vena cava right here and leads across the tricuspid valve. And I never put leads at the apex because, as you can see, the tip of this lead, and maybe just make this a little bit bigger. The tip of this lead has an active fixation mechanism. It's like a little corkscrew, and it screws into the endocardium and allows the lead to remain fixated. So there's no reason whatsoever to put pacemaker leads at the apex ever. In fact, when you put it at the apex, you get that very wide-looking QRS complex with a full left bundle branch block pattern, and that can actually lead to more problems with ventricular dyssynchrony and heart failure. So I never ever put my leads at the apex. Never say never. The only time I might do it is if somebody has hypertrophic obstructive cardiomyopathy. And then you want that full left bundle branch block to try to get the septum to not contract as vigorously. But here I have this active fixation lead, and it looks like it's right below the valve, but it's actually at the right ventricular outflow tract, which is here someplace, heading out to the lungs. So I have this in the right ventricle. The apex would be here. When I have it up in the septal area, and that's where I like to put my leads. And with that, you actually get a pretty narrow looking QRS complex. So once I screwed that lead in and checked it, I was able to pull the temporary pacemaker out. And then we have the final result here. I'll make this a little bit larger, and then we'll play it. So here's the pacemaker can in the pocket with a single lead, because he's in atrial fibrillation. We don't need an atrial lead. And then we can just play this and see that it leads down pretty straight right across the tricuspid valve and sits in a really good spot. It's a very reliable place to put pacemakers. It's got enough slack that it won't pull out, and the patient actually did very well with this permanent pacemaker. I just did this yesterday, and so he looked pretty good after the procedure. They were going to wean off the sedation and then try to get him extubated because he was moving around somewhat, and hopefully he'll still be functional after this whole ordeal. But it's a problem when you have someone with such profound bradycardia, because it's really a medical emergency. And putting in a temporary pacemaker is sometimes life-saving, but make sure that you realize that these temporary wires are just kind of hanging in there. They're just sort of like making passive contact with the endocardium. And so you can't be rolling the patient or transferring the patient to go get a CAT scan without risking dislodging this lead. You know, even though you've sewn it in place in the femoral vein, I mean, some people for that reason will put temporary wires in the jugular vein because it tends to be a little less of a problem dislodging the vein, because there you could stick it in the apex, and generally if you sew it in well here, it won't move even though the patient's legs may be jumping around. But when you put it in a femoral vein, you know, you have sort of sometimes a circuitous pattern to go up the inferior vena cava, and then it has to make a bend to go across the tricuspid valve. So you have fulcrum points all along that course of the lead that can serve to kind of like either push the wire in or pull the wire out, and then you wind up losing capture. So don't rely on femoral vein pacemakers too heavily. You know, you have to kind of make plans to do something more definitive, and obviously don't be moving the patient, don't jostle the patient, don't transport the patient unnecessarily, because you risk running into problems like we did here. But keep in mind that the TAVR really can encroach upon the conduction system, but interestingly in this patient, he went a year and a half and didn't have a problem. So I suspect it wasn't directly related to the TAVR. I think the guy's conduction system was 95 years old, and it just gave out, and he wound up with infrahis block and very unreliable escape rhythms, which is why you have to watch out for Mobitz 2. You know, type 2 second degree AV block is a serious problem that can lead to asystole like we saw here. So let me see who's got some questions here. Melissa asks if pacemaker leads get thrombi on them. And the answer is yes, that sometimes they can develop a small thrombus, you know, because now you have this foreign body in the venous system. So it turns out that a fair number of axillary veins will develop a visible thrombus if you do an ultrasound. And I would say in my experience, about 3 or 4% of people will wind up with an upper extremity DVT that then has to be treated with anticoagulation because their arm becomes swollen and heavy and uncomfortable. So that's another reason to try to put on the left side of people who are right-handed, and a lot of people will always put the pacemaker on the non-dominant side for that reason, because for those couple of percent of people who wind up with a DVT, it can be uncomfortable for weeks or even months until collaterals form, and then you wind up with resolution of the symptoms. Now, rarely you can see a thrombus on the lead itself, but we generally don't do anything about that. Usually the body just eventually dissolves it by itself. Do I use an ultrasound to get that view, Wyatt? I don't use ultrasound in implanting pacemakers. I don't need it because I'm doing a venogram and I'm trying to stick that axillary vein where it overlies the second rib. Sometimes I can't get it in that spot. 10% of the time I have to go over the first rib, but at least I know where the vein is. And it also helps avoid accidentally puncturing the artery, because the subclavian artery is there, and if you puncture the artery, especially in someone who is anticoagulated, you can run into big problems with internal bleeding The subclavian artery in particular is under the clavicle, so you're not able to compress it. The axillary artery is not that big a deal, but you don't like to make holes in arteries unnecessarily. Just let me see if there are any other questions. Is the top strip lead 2? The complex is upright. The complex in lead 2, since lead 2 is going this way, what if I put the pacing lead in the outflow tract? Then it's going to be upright in lead 2 because the electrical vector is going to be headed towards the feet. So don't look at upright and downward as being normal or abnormal. It all depends on where the signal is coming from, where the tip of the wire happens to be located. And how is the patient on discharge? Well, he hasn't been discharged yet, Melissa. He's still in the CCU. They were going to try to wean the sedation and try to get him extubated and then kind of see how he does. But at least we got him through this, huge ordeal. He was in cardiac arrest at one point. And for a 95-year-old, you never know what's going to happen. But, I don't think he was ever without circulation for a prolonged period of time. So we know that people can go several minutes and still recover. So we'll have to see. We'll have to see. And I tried to be optimistic with the family that, he's now got this permanent pacemaker, and we'll wait and see how his brain recovers from this insult. But, they weren't ready to just give up on the guy, and that's fine. We were able to fix the acute problem that occurred. So at any rate, I hope that this was an interesting discussion for you guys because, this is the world in which I live. And sometimes you see complicated problems, and that's why these live streams are more clinical. Like, what do you do with the patient when this happens? And how do you manage this particular problem? So I hope it's helpful to you. And any of you who may have missed it, you can always click on the link and you'll be brought to the recording. And if you like this material, if you enjoy this content, please find the link in the description below and just subscribe to my YouTube channel, ECG Doc. Tell all your friends to subscribe as well so that at least you'll get notification when I'm doing these. I try to do them every Saturday. Last week I was on call, and the week before we were doing a lot of stuff, the houses, renovations and so forth. Well, soon you'll maybe see my new studio, maybe next week, and we'll see how that goes. I think it'll be a lot nicer. And by the way, if you want more information about how to read an ECG, how to get into that advanced level of analysis using the physiology and everything, just check out ecgacademy.com. There's a link for that in the description as well. So until next week, this is Dr. Nick Tullo. Thanks for spending your Saturday morning with me, and I hope you have a great week. And thanks again for being part of my Saturday morning clinical live stream.